All right, it's 11:30. Are we ready for this next breakout session? I think I'll wait another 30 seconds or so, just as people come into our breakout session called Dental Care for Children and Youth with Special Health Care Needs. I'm Dr. Ben Meisel. I'm the medical director for California Children's Services San Francisco, and have been passionate about improving access to special health care, special dentistry for children with special health care needs for a long time, ever since I had one of my patients unable to get access to care as a 17-year-old, and have been lucky enough to work with some wonderful people, including the ones on this panel today. I want to welcome our speakers. We have Ann Hall, who is a graduate of Family Voices Project Leadership and the mother of a 10-year-old daughter with medical complexity, who will talk about what it's like to be a parent of a child with special dentistry needs and the challenges of getting lost in a system of dental care that currently exists. We'll also have speaker number 2, Mary McCune, who is the policy director at California Dental Association and who happens to have a brother who has special needs. And she'll be talking about new California Dental Association funding that's to be used for development of new dental clinics serving people with special healthcare needs in California. And then our final speaker is Dr. Paul Glassman, who is a national leader and advocate in the field of special needs dentistry, and who is the Dean for Research and Community Engagement at California North State University of Dentistry. First of all, I just want to welcome all of the attendees, everybody who's going to be joining us for this breakout session, and invite you to write in the chat who you are and introduce yourself to each other. Also, in a minute or two, we're going to put up a survey that we're hoping everyone will participate in. It's to gather information about who is actually attending this breakout session. And at the very end is an opportunity, if you have a story of a challenge of getting your loved one to a special needs dentistry, and you want to share it as an advocate for future advocacy opportunities, we would love to have you put in your contact information, and that will be there. It will not be shared with everyone. It'll just be shared with the panelists, so that we can call on you in the future, should that be of interest to help us. So I would like to give you 5 minutes to complete the survey. And thank you so much, Caitlin. Go ahead and start the survey.
I'll just say I noticed for the survey that for question number 3, it says, what type of insurance does your child have? Single choice. So Ben, if they have both public and private, what should they do?
Ooh, that's a good question. It was meant to actually have both as a choice.
And
that
maybe
could
they
be
can,
both
it
ways.
just says single choice in parentheses.
I think, well, so maybe that will be a failed question for us, because you're absolutely right. Lots of people have both.
You might also want to put out for question number 2, it says, how satisfied are you? And it says 1, 2, 3, 4, 5. Sometimes 1 is the best and sometimes 5 is the best. In this question, what are you, if they're very satisfied, is that a 5 or a 1? What's the best answer?
Oh, great point. Why don't we say that number 5 is most satisfied and number 1 is least satisfied. That makes sense.
Great.
Thank you for that, Paul.
Yeah.
All right, going to give it just another couple of minutes. And while you're working on that, I was hoping to introduce our interpreter, Gabriel, and have him explain how to access the interpreter services for people who need Spanish. So far, we have 12 of 26 people participating in the survey. If you have a chance to complete the survey, we would really appreciate your participation. And there's just another minute or so on the survey, and then we'll close that out. And hopefully, and right after that's done, Gabriel, our interpreter, will tell us how to access the interpreter services. All right, Caitlin, is it possible to end the poll at this point?
Yes.
Okay, thank you.
You're welcome.
Was Gabrielle able to talk about interpreter services at this point, or do we need to do that?
It looks like the interpretation services are already started. Oh, okay. We're ready. Gabrielle? Maybe? The interpretation services have been started. Oh, there we go. So. Gabriel is already interpreting in the Spanish channel. Sorry, that's why we can't hear him in the main room. He has already started, so we'll use the written instructions for that, and folks can access interpretation anytime that way.
Thank you so much, Holly. All right. Well, welcome to this breakout session on dental care for children and youth with special healthcare needs. I wanted to share in the chat, I want to thank Mary McCune from the California Dental Association for allowing us to share a copy for you, a link to last June 2022's California Dental Association journal, which focused on oral health care for people with special healthcare needs. And I was fortunate enough to get to be the guest editor with Dr. Ray Stewart, who is the chair of dentistry, pediatric dentistry at UCSF. And so we're going to share that publication with you in the chat. If you want to do more reading on the state of challenges that we're facing with oral health care access for people with special health care needs. A little bit of background of the issue. I want to just take 5 minutes to tell you that there have been barriers that we've been discussing for a long time, leaders in oral healthcare and advocacy for families who have people who need special needs dentistry. And there are a number of issues for you to be aware of. One is an inadequate workforce and the need for expansion of training dentists who feel comfortable and wish to see patients with specialized dentistry needs. Number two, challenges with payment that people often say, no one will take Medi-Cal dental program because the low reimbursement rates prevent dentists from seeing those kids. Those reimbursement rates have increased over the last couple of years, but they're still quite low. Number three, physicians and dentists don't speak to each other, right? So when you have a child with special healthcare needs, it's important for there to be good communication between the physician and the dentist, and they often use different electronic health records. Some of that is changing, but it's still a challenge. Number four, the only option in the past for many people with special needs dentistry needs was general anesthesia dentistry. But in reality, if there were behaviorists or people to help in the dental office who specialize in working with people who have special needs, it's possible to decrease this number of general anesthesia sessions required for dentistry. And that's a goal in the future, to decrease that need for general anesthesia dentistry. And Dr. Paul Glassman will talk more about that later in this session. Number five, the lack of virtual dentistry. So the opportunity for dental care to go to where patients live and thrive. And I think Dr. Glassman will also be talking more about this. Number six, special needs dentistry care deserts, places in the state in California where there is no access to centers that offer special needs dentistry. And Mary McCune will talk a little bit about funding opportunities and our hopes to increase the number of centers and identify those parts of the state where that's really needed. Some solutions up to this point have been, number one, to update dental education and curriculum to better prepare dentists to confidently accept special healthcare needs patients into their practice. There are a number of opportunities happening now. I know University of Pacific is creating an online training opportunity for dentists to become trained in special needs dentistry. And there are other efforts such as those happening. The integration of medical and dental provider care and combining electronic health records, that is happening in various places. I know at UCSF, where I get to work sometimes, they are implementing that as we speak. Number three, bringing dental care to where people with special healthcare needs work, play, and live. There are efforts at increasing virtual dentistry opportunities. Number 4, creating, designing, and equipping dental facilities specifically intended to serve special healthcare needs patients. There will be in the next few years opportunities to increase the number of places that do this. Number 5, incorporating care coordination into the practice workflow of dental care to better match providers with patients so that it reduces the no-show rate and it enables patients when they show up at the dentist to actually go through with the dental care and not be turned away. And finally, enabling providers in the Medi-Cal dental program to bill for extra time needed for working with special needs patients, or to have special ways or extra ways to bill for the care that's being provided. Well, that's enough for me. I just wanted to give you a little bit of a background, and I'd like to now introduce our first speaker, Ann Hall, who again is a graduate of the Family Voices Project Leadership and a mother of a 10-year-old daughter with medical complexity. Take it away, Ann. Thank you.
Thank you, Ben. It's exciting to hear about the things that you're talking about. I have to be frank that I'm not seeing those yet with my experiences and what I've reached out to. So that's going to be what is reflected in what I speak about. But believe me, there is hunger. There is a lot of people out there that would love to have the things that you're talking about. So it's exciting to hear about these prospects, and I'm glad to be on this panel with people that are in positions to communicate that, to help influence and the training and our systems and policies to help with those things. Because in preparing for this, I reached out to a few individuals. I sent about 10 text messages, literally like 5 days ago, and about 5 people wrote me back, and there was lots of common themes that I'll be bringing up. And I'm going to share my screen, hopefully. Okay, can people tell me, can you see everything okay? Terrific, I see shaking heads. I encourage you to please, especially parents, providers, anyone that is here at this panel, put stuff in the chat if it helps you to engage with what I'm talking about and help to connect with our fellow breakout attendees. I dearly miss the Health Summit. I'm pleased, or the in-person, although I certainly understand why we're doing it this way. So I encourage people, if you can, please actively participate, because it's a really special energy that I felt this morning, and hope we can bring of people connecting.
Ann, I'm
Yes.
sorry to interrupt just for a moment. Anyone who wants to ask a question of the speakers, please do it in the Q&A buttons down on the bottom of your screen rather than in the chat.
Thank you for clarifying. Yes, chat. If you want to echo something, though, if you want to be like, yeah, me too. So don't crowd up the Q&A, but please do put something there if you have a question.
Thank you.
Thanks for that clarification. So I figured out that this is my 8th Health Summit. So I'm super pleased that I got connected, because it has really changed the trajectory of my life as a caregiver, my daughter's life. And each time when I almost said drill down, I keep using that for this dental panel, and I'm trying to stop myself. Each time when I focus on something as a facilitator or a parent perspective, I learn things that help me to bring better care to my daughter and to those around me that I interact with. Because my day job is with the Federal Reserve Bank of San Francisco, here's my disclaimer that my views are mine alone and don't represent the Federal Reserve System. Not that I anticipate getting Q&A about interest rates, but there we go. I also want to thank the other parents that I reached out to who generously shared their experiences and ideas. Hopefully some of our thoughts and wishes won't be as mythical as this lovely little tooth fairy image that I found for the front page. And advancing, why is my Okay. Oh, what's going on here? Trying to go to the next slide and it's not cooperating. Maybe from beginning. There we go. Okay, can everyone see my little cutie pie, 10-year-old? Good. So this is the cutie pie that first brought me to the Health Summit nearly 10 years ago. Love the hearts. This is Margot. She has a rare chromosomal abnormality and it presents with medical complexity, intellectual differences, and challenging behaviors. She is eating, as you can see, probably not something that's super great for dentists, but she also has a feeding tube. She has lots of things that complicate her medical care. And she also astounds me all the time with her intentions around communication, her powers of observation, and her emotional presence in each moment. And I have her consent to present this. We talked about it last night. So before getting into this issue of specific to dental care, I want to mention a word and a concept that applies to lots of dynamics and has been on my mind a lot lately. And this has to do with all different things, with not even just navigating care for specialized medical kids, but any situation is burden. Where in any given dynamic might we be placing burden, visibly or invisibly? To whom does the effort hot potato land with? I'm not talking about the burden of care concept, describing the physical, emotional, social, and financial problems that can be experienced by family caregivers. I'm thinking about this almost like a mathematical or economic framework for any given transaction or policy proposal. Where does burden exist? How much is it? To which parties is it falling to? Are there structural ways we can decrease it or spread it around more? And if we identify a lot of burden, what does that tell us about the friction and design of the things happening? And if there's literature about this concept or somebody already knows some things, please put it in the chat, put it in the Q&A. It's just been percolating in my head. And spoiler, if it's not being made visible, then there's a good chance that it's implicitly falling to caregivers. So while I don't expect our dental visits to look like this, I am actually very pleased to have a recent one that looks like this with my daughter there, restrained. And that's because we finally found a dentist that will actually do interventions and has the skills and experience to treat my child. For years, we went to other dentists that would attempt to do care, but were really just looking at her teeth for a few minutes. And when my daughter wouldn't easily oblige substantive care, they would in essence give up. And to be frank, during those years, I was, and frequently still am, consumed with her many other health and educational and developmental needs. For a while, I mollified myself with the idea that they were just baby teeth and I would get serious about things soon. But it also hung over me and caused a lot of guilt, and we missed windows of opportunities for care and hygiene for her. In addition, I felt like I was facing it all on my own. The pediatrician, who is responsive, and we really like her, and this is in no way judgment about her, it's the things that Ben mentioned in the beginning about that disconnect between our systems. She would ask if we were seeing a dentist and brushing, and I would kind of shrug and say, sort of, we try, and she would check that box in our well visit and move on. Unlike other medical issues in sort of air quotes, or other developmental issues, this more easily falls between the cracks for us in our family and among many others that I spoke with. So the issues we face, dental care providers, and this is of course the most obvious. When you move to a new location, people say, oh, do you have a doctor? Do you have a dentist? The provider is what becomes sort of top of mind to establish that care. So I alluded to our challenges already, but let's go through the winnowing down process that I and many caregivers face. Finding a provider skilled enough to do real care, that accepts Medi-Cal and is accepting new patients and has access to anesthesia facilities, which feels like sometimes our only option, or the point that we get to when we finally get to a good dentist that is capable to handle some of the complexities that they've found with our kiddos. Oh, spoiler. And just as an example of another parent perspective, a parent of a 9-year-old with intense medical needs finally at age 9 recently got a first set of x-rays and a full appointment because the parents gave extra medication intended to control seizures to partly sedate her. So they got creative. They're like, we got to do something for this kid. And that's what they figured out to do. And the last thing that I really want to just emphasize is the judgment. We really, it's tough to find dental care providers that don't judge. And as another parent said, they start disciplining my autistic, traumatized kid for having a meltdown, not helpful, and wouldn't stop even when I said stop. We face ignorance, insensitivity by dentists about challenges kids face that trump dentistry. That is, preaching that my kid should not be eating what he does when my kid's on a strict medical diet for seizures. Or I already saw in the chat about medications that are really hard on teeth. So I'm excited, Paul, for whatever you're going to talk about training that can help with some of those things that really just cause a lot of heart sickness when we're trying our best to do care. So I personally feel so lucky that we found our dentist a few years ago, but I didn't hear about him from any medical or formal structure. It was the special needs parent grapevine because I happened to ask and they happened to tell me, and he happened to check all these boxes and was accepting new patients. My last visit, I signed something because it just was a standard form that if he's full, then as my daughter's getting older, she might be kind of kicked out, so to speak. And I kind of had a mini panic attack. I was like, I don't know what I'm going to do then. So at my daughter's last visit, another one, I was so relieved that something mysterious, because whenever she in some way indicates dental pain, I'm like, oh gosh, what does this mean? Is it real? Is it not real? What are we going to do? And this dentist handled it so calmly. It was just some baby teeth that were wiggly and she didn't really know what to do. I couldn't get in her mouth to check it out. And so spontaneously, as he left the room, as he was leaving the room, I yelled, "We love you, dentist so-and-so." And then later I wondered if that was inappropriate, but it shows you the feelings that I get when this stress in my life is taken care of in a way that supports me and my daughter. So issues we face with dental care in general, that even with the great dentist, this great dentist, I still feel like I need to figure things out on my own and have this burden each dental visit. So here was just my answer to the receptionist check-in last week of, okay, so we see you're on the schedule, you know, what are you here for? And the same sort of conversation I had to repeat when we went with the hygienist who was trying to figure out what was happening was, I think we are here for a cleaning, but I'm not really sure because my daughter doesn't exactly do cleanings. And this is March, and we've had this scheduled for months and months, but the dentist just saw my daughter in December for an extraction because she'd indicated some subtle signs of discomfort and irritability. So we had that tooth pulled and we're here. But we have the sedation time booked at the hospital for June that we booked back in November. And this is March. So why am I here? Well, I don't really know, but it was on my calendar. So I never know what's going to happen at the dentist's office when we go because I don't know what they're prepared for. I don't know what they think they can do. It's kind of a mystery, and it's something on my calendar and it's scheduled, and I feel like I'm at least trying. So the burden is on me to explain and try to fit into a system and schedule that doesn't work for my daughter. And he's a great dentist, but I on my own thought to bring this baby and the toothbrush and the iPad with lots of content loaded on the night before because the office has terrible cell reception and Wi-Fi. And my daughter needs the distracting entertainment closer than the television on the ceiling. So these are all things that I was like, oh my gosh, I need to do this and that. I felt like that pack mule for the burden leaving to go to the office. Like, do I have all these things? Get the blanket. Oh my gosh, because I know she's going to need it and it's going to help even just a little bit to try to get through this. The other thing is, of course, there's no integration with my medical patient portal, our primary care physician, or all the other specialists we see with the insurance, with the billing, all the other systems I struggle to wrap my head around already. And then it's like a whole new map that I'm trying to navigate. And I'll just also add that transparency in billing, that when I got this bill a couple, I don't know when, from our terrific dentist, it actually had an extra charge for Medi-Cal for like special needs. And so I reached out and was like, what's going on? What does this mean? Am I getting charged more? And their billing explained it's just something that we're able to do for Medi-Cal to try to increase billing. It's not that you're getting charged extra because of your child, that you're going to have to pay more out of pocket. But I had to call because I didn't know that. So as we do these things, I'll advocate for transparency in it. And of course, there's much more than just scheduled dental visits, although that's easier to focus on sometimes than to whole person oral care. So we can just go through the list. Challenges and guilt around brushing, challenges and guilt around flossing, which is a whole different skill and sort of sensory issue. Figuring everything out on our own. Understanding if my child's having issues because she doesn't communicate or register pain the same way. And yet I also know that if I have a toothache, I'm in pain, discomfort, distracted for all the other things I'm trying to do in my life. So I know this is critically important. And yet as a parent, it's super hard to do because I can't get into her mouth. I don't really know what's going on. So it's this like black box that's really tough for me to approach. Then helping my child understand when she's actually having an issue. She doesn't get the concept, I don't think, of baby teeth and big teeth. And so this wiggling of the tooth, it was hard for me to even explain to her after the fact what had happened. So this is from one parent they're incredible of what they figured out. No support on the teeth brushing. Both her dad and I have to be involved to get them done well. And in this household, I'll add the father travels frequently, so I don't know what they do then. She says, we created a routine, brush with a tiny bit of toothpaste, have a baby washcloth soaked with water to wipe her teeth and tongue a bit after, as she won't spit, then a syringe with like 5 to 10 mils of water to help rinse out her mouth more, and she swallows that. I am just tired just thinking about that, let alone trying to do it twice a day, you know, with this woman on her own, this mom with the dad's traveling, especially, not to mention the like 20 meds she's already giving her kid throughout the day. So from another parent, he has his teeth cleaned 4 times a year. I help him brush his teeth, but it's not enough. He keeps having cavities. They use the gas to keep him still. I'm not a fan of this, but I don't know if there are other options. So I pulled our good old sort of, you know, classic heart chart here, I mean a medical chart, that I feel like we're in this trap of a lack of support around and physical abilities with the day-to-day hygiene. So we rely on the hard to schedule sedation, but at least it's something, and that there's no real middle ground. I did hear from one parent that had gotten supports through ABA, like dental visuals, YouTube videos on dental visits with dental social stories, also suggestions of modeling and hand-over-hand assistance. So I want to be balanced that there is support out there. It just really is tough to find sometimes, and it's up to the parent to have to be asking about it a lot. So what if, from a parent perspective, there was more integration between the medical systems and the dental systems we deal with? Not sure how realistic it is. I'm sure it's pretty complicated. I'm just throwing out my wish list here. Dental training included elements of empathy, a meaningful unit or rotation focused on children and youth with specialized healthcare needs and their caregivers, because it's very different to just treat the kid, as well as also treating the parent and their feelings and them as an expert or what they're coming in with. Having dentists experience brushing and flossing their own teeth with simulations of different disabilities. Maybe that exists, and that's terrific. Fun classes to help kids with disabilities learn brushing, but not just a one-off, like, oh, let's do this once, and then it falls to the caregivers before the habit has set, and then to support with when there's behavior changes. Continuity of care akin to the medical model of whole health, not just the more common focus of the dental office visit, sedation appointments as the only option. And then I will just add, and this is just sort of to plant the seed for our discussion later, that I did ask this gem of a dentist that has a true passion around treating medically complex kids about some of these things I was hearing in pre-conversation about the funding to try to establish some of these special needs dentistry clinic surgery centers. And he relayed very quickly at the end of this appointment that he's kind of in the later years of his career. This was not something he felt he could take on the risk of by himself. And he'd reached out to the local children's hospital to see if who I really like. I think they're great. This is not judgment on anybody or anything. And he'd reached out to that local children's hospital and he'd gotten no response. And he really apparently had this nice vision in his head of what he thought it could be, but it's not going to go anywhere, at least from him as a stakeholder. So I, as a parent, am like, okay, what do I do? Help me, my fellow panelists now or in months to come as things are being settled to see how I can advocate, because this was my information I got from him. So what can I do to try to help I'm in a major city in California. How can I try to influence change? And so I will end in gratitude that we found the dentist that we have. I feel incredibly grateful about that, and who I tell I love, because I'm overcome with gratitude at the end of a visit, and a wish that somehow he miraculously just keeps working forever, because I don't know what I'm going to do without him. I really don't. So I'm hoping for lots more ideas and resources from our panelists, and I will close with that.
Thank you so much, Anne. I see one question in the Q&A, and I think I'm going to answer that just typing out the answer, because it's a kind of it's a more personal issue about not being able to get access to dentistry in San Francisco for an older teen, and I can write out some information there. So if you have questions for Anne, then put them in the Q&A and we'll get to them later. Let's move on to Mary McCune, who's the policy director at California Dental Association, and who happened to have a brother with special needs. And she is going to talk about new California Dental Association funding that Anne had referred to, in talking to her dentist about, in developing to help them develop new dental clinics in California, serving people with special healthcare needs. So I want to now hand it over to Mary McCune.
Thanks, everyone. Can you guys see my slide deck? Yeah, great. All right. Also, I just wanted to thank Anne for her presentation. I know that Dr. Meisel mentioned my own family member experience, and I just want to say that a lot of the stories that she portrayed, I know that my family can personally relate to, and I'm sure that a lot of people in the audience can as well. So anyways, my name is Mary McCune. I am the policy director at the CDA Foundation, and I work very closely with our entire team that does a lot of advocacy on special needs. Today, I'm going to be going over a couple of different things. First, I'm going to talk about a budget ask that we were successful in achieving that Anne had referenced to earlier in her presentation. It directs $50 million to building out statewide facilities and infrastructure to better serve patients with special needs. Then I'm also going to fill in some background on how CDA has and currently engages in advocacy as it relates to special needs dentistry. And I'll also provide you with some context on how the State Office of Oral Health prioritizes access to oral health care for patients with special needs. And then lastly, I'm going to talk to you about some opportunities for parents and families to advocate for new initiatives in the legislature this year. So to give some context on how CDA was successful in our $50 million advocacy ask last year, I want to talk to you about the status of last year's budget. The state had really an unprecedented budget surplus 2 years in a row. And so with last year's budget having $97 billion in extra revenue, it broke actually 2021's record of about $60 billion in surplus. But since then, this has really gone down and projections are now in a deficit. So I wanted to give you that context about how wild of swings the budget experiences and how that really informed our advocacy tactics. So with a large amount of money on the table, the budget asks from the stakeholders throughout the state grew, and California already had a lot of problems to solve, including the COVID-19 response, wildfires, homelessness, housing, inflation, especially on gas prices, and then there was the drought. And so since we know this was likely going to be a one-time surplus, CDA really wanted to advocate for strategic one-time investments to build infrastructure and workforce and to expand out dental care. Our 2 budget asks were included in the final budget. One was really to expand the workforce for the dental offices, but then there was this other $50 million ask that over 2 years, we would be able to build out dental clinics serving patients with special healthcare needs. And then we also advocated for $10 million to expand out community-based dental rotation sites for dental schools and their students throughout the state as well. So to put the special healthcare needs into context, this has been an outstanding issue and policy priority for CDA for a number of years. There are multiple reports highlighting the issues over the years. There are 3 reports actually between 2014 and 2019, highlighting the needs of vulnerable populations and patients with special healthcare needs, both inside and outside of the Medi-Cal system. The state auditor and the Little Hoover Commission both did reports on Medi-Cal dental that included looking at patients with special needs. And then the Legislative Analyst's Office also did a dental access report for patients with special needs. Medi-Cal has improved over the last 6 to 7 years, as Dr. Meisel had referenced, but there's still a lot of groups and a lot of people left behind, and particularly those with physical or cognitive disabilities makes it challenging for them to receive routine dental care in traditional offices. Back in 2020, CDA pursued legislation that would have allowed dental schools to pull down federal funding to build additional capacity themselves, but that was really scrapped once COVID hit. Then we saw a budget surplus in 2021, so we put together a proposal to get funding. This wasn't even approved in 2021, so we really made it a top priority in 2022, and eventually we found success that way. Oops, I'm sorry. Let me go back. So what is this $50 million pot of money going to do? Put simply, this pot of money is going to be used to build out new and expanding existing buildings and settings. These grants are used or can be used for construction costs, specialized equipment. We're also looking to see how it can be applied for training as well. And since we were trying to fit this into a one-time ask that could have a long-term positive effect, we really focused on dental setting buildings, knowing that expanding a setting can really be challenging, especially when Medi-Cal rates are pretty low. So we really took the if you build it, they will come approach. As Dr. Meisel also referenced, it's $50 million over 2 years. The grants will be available for up to $5 million per entity applying. And so hopefully we'll see kind of a variety of people applying. Minimally, we're hoping it will help 10 sites throughout the state. But if we're looking at more creative approaches to applying for these funds, such as the use of training, hopefully that will kind of downsize the amount that people are applying for, and then would end up being able to apply for more settings throughout the state. The grantees of the grant have to commit to serving at least 50% of the patients seen in the facilities built or used with the grant money for the next 10 years that they start receiving the money. And the other requirement that the applicants must have is that they must also be Medi-Cal enrolled providers. So here are some additional details about the grant. The budget language used special needs intentionally over the term individuals with developmental disabilities or IDD, because we really wanted to use the term that was broad enough to also include medically fragile patients or elderly patients with cognitive issues like dementia or Alzheimer's. There is also an internal plan to create a priority for applicants that can reduce the need for sedation or anesthesia when possible. We recognize that sedation is often important for this population, but we didn't want this to be only to fund anesthesia settings or just anesthesia only settings. Anesthesia is expensive and it brings medical complications. It's unlikely and unwise that we can really try to solve the underlying issues with only building more sources of general anesthesia care, and that we really must take the time to develop systems that a lot of people from various settings can use that have multiple needs of services. So the opportunity that this represents is to benefit everyone, including people who might get dental care in a less complex way. People who might get general anesthesia care using shorter wait times. Dentists who want to serve people with complex needs will hopefully be able to do so. And payers could see fewer consequences of long wait times. And we also hope to see some geographic diversity throughout the state. So here's where we are with the grant program today. The grant is being administered by a state agency known as the California Health Facility Financing Authority. We call it CHFA. And this is a state or a branch within the state treasury's office. CDA is really, really excited to be providing technical assistance on this grant development because CHFA, they have a lot of expert knowledge in how to administer grants or loans for building health facilities, but they don't really know anything about dentistry. So CDA is helping to provide a lot of information on how dentists are permitted with sedation, how a dental office actually works, the business side of it, to make it so as many dental providers as possible who are interested can be eligible to apply. And the stakeholder meetings for this began in November 2022, and we're hoping to have the application open to applicants by summer of 2023. At the end of this presentation, I'll put in the chat, there's a website that you can go and sign up for updates for this grant. It's www.treasurer.ca.gov/CHFA/dental/SD as in dog, CGP.ASP. And again, I'll put this link in the chat as well. And so we don't have any upcoming stakeholder meetings planned. CDA is not the convener of this, it's CHFA, but any future updates on those meetings will be posted to that website. So moving on, I do want to talk a little bit about what's next. So CHFA has until 2028 to give out the money, all $50 million. There's likely going to be multiple rounds of funding. What we know right now is that 25 million, so half of the money is already allocated to CHFA. We're waiting for this year's legislative budget to allocate that second half of the money. Right now, we have no indication that that's not going to happen. But as I mentioned earlier, we are going through a huge state budget deficit. So we're unsure if the governor is going to want to readjust his priorities. And so as we get clearer indications of whether or not that's going to happen, we'll be making sure to reach out to stakeholders, including family voices, to help advocate and bring this policy priority up to legislators to help enforce that, to continue the funding. So I want to move on to the Office of Oral Health. It's a department within the state government that not a lot of people know about or understand the purpose of. So the primary functions of the Office of Oral Health and its local oral health programs throughout the state is to primarily inform, educate, and assess. The data gathered through these assessments helps to not only identify disparities, but it's really essential in painting the pictures necessary in pushing forward change in state policies, reallocating resources, and investing in new programs. Actually, a lot of the data that came from Office of Oral Health in identifying where Medi-Cal benefit utilization rates are was really helpful in advocating for the CHAFA special needs grant. So that's just one example about how we kind of utilize and leverage the data that this department collects. The Office of Oral Health works very closely with the California Health and Human Services Agency, who released a strategic plan that calls out how access to dental care for patients with special health care needs is a priority. Specifically, the plan states that it intends to provide opportunities for Californians with intellectual and developmental disabilities, regardless of the severity of their disability, to prepare for and participate in competitive integrated employment. And so using these types of plans is also really good leverage. It's one thing to state it, but it's another thing to use the plans and what's said in it to help leverage and advance additional priorities, including budget allocations like the 50 million pot of money that we advocated for. Local oral health programs throughout the state work to prioritizing shoring up health disparities and access to care for all types of populations, this one included. And I wanted to really focus on a community where the Office of Oral Health has seen improvements. San Francisco has actually made a concerted effort using a public health approach and tracked health outcomes. They promoted policy, system, and environmental changes. And San Francisco created a partnership and implemented universal screening of kindergarten children. They provided them data and helped them to link it to all 10 essential public health services in the county, from assessment to policy development to assurance functions. The prevalence of tooth decay in kindergarten children actually, through all of this work, declined from 60% in 2000 to 32% in 2017 to 2018. And it actually declined in all population groups. The Office of Oral Health is now trying to replicate this type of approach in other counties. And that's really, to reiterate, what they did was they leveraged a lot of the existing public health services and coordinated them, used coordinated care approach. But again, this is one example of how the Office of Oral Health is using public health programs, but I still do want to emphasize that disparities still exist, even though we are declining rates in children or kindergarten tooth decay. So now I'm going to move on to advocacy opportunities. There's actually going to be a lot of opportunities to advocate and provide feedback this year. This year alone, CDA is sponsoring a bill aimed at establishing patient protections and dental plan accountability. To give you some context for why we chose to take this approach, I wanted to go back to the enactment of the Affordable Care Act back in 2010. This resulted in a lot of reform for healthcare plans by standardizing benefits, increasing transparency, and adding patient protections. But the one thing it didn't cover was dental benefit plans. And so a lot of those protections that were established, dental benefit plans didn't have to adhere to any of that. And so this bill is really trying to create parity in what healthcare benefit plans have to do and applying it to dental benefit plans. So it does three things primarily, our bill. It would prohibit plans from establishing waiting periods. And so several commercial dental plans actually require a waiting period ranging from 3 to 12 months before enrollees can access their benefits. These are really arbitrary waiting periods that are often imposed on medically necessary services like crowns or root canals, and it limits a patient's ability to access care when they need it the most. Waiting periods leave patients with really few options. That you basically have to pay for the service out of pocket, you have to delay care, or you have to risk the condition worsening until the waiting period is ended. Secondly, this bill would really prohibit commercial dental plans from imposing exclusions for enrollees with pre-existing dental conditions. The most common example of this is often referred to as the missing tooth clause, in which dental benefit plans can deny coverage for a bridge or an implant for a tooth lost prior to gaining coverage to that specific plan. The dental benefit or the dental plans would be able to deny coverage for dental procedures related to genetic conditions such as cleft palate as well. And then lastly, this bill is going to require dental benefit plans to undergo rate reviews. This rate review, which is already required on the medical side, would improve dental plan accountability and transparency regarding premium rate increases. With dental expenditures and out-of-pocket costs becoming borne by consumers, there's a greater state oversight that will ensure consumers are really receiving value for all the premiums that they're paying. So as this bill moves forward through the legislative process this year, CDA is going to be keeping family voices up to date on opportunities to submit letters of support to committees and local legislators urging a yes vote. And with that, that's the end of my presentation.
Thank you, Mary. There was one question in the Q&A, and maybe you kind of referred people to an online link, but I'm wondering if you can talk through what's the timeline for the application process to apply for the money to create special needs dentistry clinics?
Yeah, the process hasn't actually been outlined fully. What we're expecting that CHAFA will end up doing is reviewing applications on a rolling basis and awarding application funds on a rolling basis. They have until 2027 or 2028 to kind of expend all $50 million. So it really depends, I think, on the applications they receive. The data that we're providing as CDA to CHAFA is trying to provide data sets overlaying existing sites that we know already provide dental care to special needs, data sets from the regional centers to show where clients are located. It's really trying to paint a picture of where the dental deserts are, because that will allow us to, well, it will enable CHAFA to help prioritize applications from those dental deserts. So they're having to weigh a whole bunch of different things. They want to be able to provide awards to dental deserts. They also want to get the money out the door so you can start having increased access to care regardless. So trying to weigh that as they get applications in is really going to inform how they ultimately determine those awards.
Thank you for that. I know that, I mean, Dr. Glassman can speak to his own university and whether they're going to be trying to put in an application for any of this, but I know UCSF is. I'm pretty sure that University of Pacific is in our area. So, so a lot of the organizations and training facilities that are interested in serving people with special healthcare needs, that they are definitely preparing these applications. And so I hope you can encourage your dentists and your medical care centers that have dentistry services to consider participating, because it's a really exciting way to increase the access to this care. Speaking of which, I would like us to now move along to our third speaker, Dr. Paul Glassman, who is the Dean for Research and Community Engagement at California North State University of Dentistry. He's also a national leader and advocate in the field of special needs dentistry, and it's been my honor to work with Dr. Glassman on a number of projects, and want to welcome him here to talk about shortening the line.
Great. Thank you so much, Dr. Meisel. I appreciate the opportunity to be here and participate in the panel. Let me go ahead and start to share some slides here, which you should be able to see now. You know, I do want to say a couple things before I jump into the slide presentation. One being that I've been involved in this area of trying to improve oral health and oral health care for people with disabilities for a long time. I got my first, actually was a federal grant when I was still a resident in a residency program in 1972. And if you use the advanced mathematics, that was more than 50 years ago. So I've been involved in this area for a long, long time. I think things are better now. I've seen lots of improvements, some of which I'm going to just touch on in the next few minutes, but clearly we have a long ways to go. And I want to maybe set some expectations. I don't have all the answers that I'm going to present to you. I have a couple of things that we're working on, hopefully a couple of useful things to say, but there are still many issues that have been well described, particularly by Annie, so I appreciate your presentation, and by others. Many issues that have been described that we still don't have answers to, and will probably continue to be issues for some time to come. But there are some new things happening and some things I think worth paying attention to. So let me start with the just a little bit of historical background. And as Dr. Meisel said, I've been asked to emphasize the area of sedation and anesthesia. There's lots of things I could talk about if I had all day to talk, but I don't. So I'm going to really focus my remarks on really two things. One is the issue of sedation and anesthesia, and a little bit towards the end about some things, some suggestions for maybe some things that parents or caregivers can do. A little bit of historical perspective. So, this slide just is a survey, just a note that I did a survey about the availability of what some people call hospital dentistry. That's often referred, the way that people refer to sedation or anesthesia, in 2008. So that's 15 years ago, and we found pretty much the same thing we find today, that there were very many dentists trained to provide this kind of service. Dentists felt it was not economically feasible, and that hospitals were reluctant to give very much operating room time for dentists to do with people with disabilities. I was involved in 2009 with a conference, a national organization, which I was president of at that time, developing a consensus statement about all the ways that people with disabilities could have access to dental care and successfully get good oral health. And you can see from this list, it included a couple things at the top, which are what I call the pharmacological or the drug-based approaches. That's anesthesia and sedation. But all the stuff at the bottom, behavior support, physical support, psychological support, social support, prevention strategies, these are all things that we know can make a difference and keep people healthy. And yet it was pretty clear that these were very underutilized. And the reason was the consensus statement that these options are not used because of lack of money, they're not paid for, there's lack of training, there's lack of awareness, and there's policy barriers. So we have a whole range of ways of addressing oral health for people with disability, but we don't have a policy and payment and training environment that emphasizes the full range. They tend to focus more on anesthesia and sedation. In the ensuing 15 years, there's been a number of different things I think make me more hopeful now as we have reached where we are now. These three things, which I'll just touch on each of them, something called minimally invasive dentistry, which I'll explain in a minute, community engaged dental care systems, and adoption of mouth healthy habits. So the idea of minimally invasive dentistry, that's referring to the fact that dental care used to be primarily a surgical specialty. If you had a hole in your tooth, the only choice the dentist had was to have a dental drill and drill out the hole and put a filling in there. But now there's all kinds of things with funny names called remineralization or buffering agents or risk assessment or caries arresting medications or sealing caries. I don't have time to go through the details of what all those are, but just to say there's a lot of different techniques and materials and methods that are available now. And the exciting thing about all of these things, these are options that dental professionals, dentists, and hygienists can use that can actually treat disease and keep people healthy, that don't require the presence of a dentist in person, although the dentist might be evaluating, supervising, and prescribing, but don't require the presence of a dentist in person, don't require a dental drill, don't require local anesthesia, and can be performed by someone like a dental hygienist in a place like a residential facility or a daycare program or some other kind of community location. So it's a very exciting time just in terms of the science and the methodology that's evolved to allow us to have tools that can keep people healthy without everyone needing to go to a dental office for any kind of dental intervention. A second development that's taken place is what I call the development of community engaged dental care systems. So again, this is similar to what I just said, but it things that have taken place to allow us to think about a dental care system as being centered in the community, where the dental office is a very important part of it and the dentist is an important part of it, but it's not the only part of it, that there are others, community structures, other places where parts of the dental team can be using some of these tools that I just talked about in the previous slide and provide a system of care that's much more likely to reach people early, keep disease from advancing, keep people healthy, and keep them from needing, in the end, anesthesia or sedation. A quick example of one of these community engaged oral health systems that I've been involved in developing now for close to a couple decades now is something we call a virtual dental home. And I could probably just show you this one slide as an example of it. This is a young man who's in his mid-20s. He's sitting in a chair in his residential facility. He's got a mask over his eyes because he didn't like the light, but he's someone who Well, that was his choice. He's someone who has had all of his previous dental care done in the hospital under general anesthesia. And yet, by having a dental hygienist being able to go to the place where he lives, a familiar environment, non-threatening, to be able to slowly work up to having some things done. She's able here, she's taking x-rays of his teeth. She's able to do complete cleaning. She's able to do preventive procedures, some of the things I just talked about. She's able actually now to do some small fillings that don't require anesthesia or drilling. And I think that this young man is never going to have to go back to the hospital again. So it's a complete change in his life from someone who always required dental care in the hospital environment to now the ability to keep him healthy in his own home on an ongoing basis. And in no small part, this just has to do with the fact that it's a place that's much more comfortable to him. You know, walking into a dental office is pretty strange and scary for most people in our society, and let alone someone who's not really fully aware of what it is and what's going on. And in this location, people can do, with using portable equipment, all kinds of those procedures. This is a dental hygienist in a school. This happens to be the nursing office on a day when the nurse wasn't there. So just using a portable chair, and she's able to do things like the application of this material called silver diamine fluoride. It's just one drop. It's a liquid. One drop of this liquid can stop the progression of decay. It's only been available in the United States for a few years, so it's a great new tool that we have in our tool chest. This is an example of someone with you can see a small hole in the tooth. And typically what happens for that small hole is nothing until it gets to be a bigger and bigger hole. And then at some point, the individual has a toothache, and then they start either acting out, or if they're in some kind of school, not learning in school. And it turns out now we have the ability for the dental hygienist, with the proper training and supervision by a dentist, to be able to repair that with, again, no drilling, no local anesthetic injections, put a filling in there that can last as long as a conventional filling and stop the progression of that decay. So the point of all this is that we have some fabulous new tools that allow us to expand the reach of our dental care systems, allow dentists who are part of these systems to be able to reach into the community and reach people much earlier in the disease process, and reduce the need for end-stage repair that can be quite complicated and expensive and hard to access, as we've been saying through most of this panel. A third new development is some better understanding about the adoption of mouth healthy habits. Mouth healthy habits I just referred to as sort of basic understanding about brushing and eating. And again, he made some good points about that may sound simple, but it isn't necessarily simple. That can be quite complicated to get someone who's resistant to even toothbrushing or other kinds of things to do it. But we have some, and I don't have time to go into it now, but we have some better understanding now of what causes these kinds of adoption of mouth healthy habits to be successful, how to gradually use desensitization techniques and other things to make those things more important. And actually, I think it's worth underscoring the fact that what people do on a daily basis, basically brushing and eating habits and using fluoride toothpaste, those have much more to do with dental health than anything a dentist or hygienist is going to do to them. So this is really a very critical part of keeping people healthy and out of the need for sedation and anesthesia. So very important, this development of what we're calling community engaged oral health systems. And I didn't mention before, but let me just make sure I add that teledentistry and the connection of dentists into these systems, maybe in a remote way, is a very important way that we're linking the dental office with what happens in the community, where before we had the whole teledentistry system, it was much more difficult. People who did stuff in the community were much more isolated and separate from dentists, and now they can all be part of one system of care. Now, jumping forward to 2020, there was this report. Mary, you showed several reports done by legislative or other committees. This one was done in Sacramento about the general anesthesia. It was called Painful Realities, General Anesthesia Access. And this was particularly focused on the Sacramento area, but it wasn't too different. It's not too different in most of the state. I won't go through much of the report except to say there was a whole series of 14 recommendations, but the two worth noting here were about the issue of general anesthesia. So one was to expand operating room capacity for dental cases. In other words, have more places where people could get this kind of sedation or anesthesia care. And you just heard about the wonderful work that the California Dental Association is doing to make that a reality. But the other thing that I think is really critical that not get lost is to support and raise awareness of the alternatives to general anesthesia. In other words, how do we keep people out of this line? And in some parts of the state, these lines are just inhumanely long. We have people who are waiting for a year or sometimes 2 years to get into a dental situation where they can get dental care. I mean, imagine that you've got dental problems that are severe enough. You're told you need to have your care in the hospital. And then you're told, we'll get to you in 2 years. I mean, obviously things are not going to get better in the ensuing 2 years, but if you develop a serious infection or you get physically sick or you're in severe pain, then we'll bump you up in the line and push everyone else down. It's just a terrible situation. So it really is critical we think about shortening this long and inhumane line. And the idea being, if we can keep some people, not everybody, some people who might be able to benefit from alternatives to anesthesia, if we can get them that kind of oral health care that they need in some other way, and we can make the line a lot shorter, that means that those people who really need to be in the line are going to be able to get the care much more quickly. And that, combined with the special needs funding facilities, we think there's a real option for making the people who really need anesthesia care, making it much more available in a way that's really can help. So how do we go about shortening the line? Well, as I said, I've been in this field for 50 years. I've seen a lot of things that have been tried. Some of them have had some benefit. Many of them have seemed like a great idea and really didn't produce much results. So we have now gone through a design process, started with a series of focus groups with dentists. We asked dentists, and we also asked behavior support specialists what kind of things would help to keep people be able to have treatment in office as opposed to sedation or anesthesia. What were the barriers? What would make a difference? The first focus group was with a group of behavior support professionals. And among other things, we asked them, of the people you're currently working with, because they were already working with a lot of people, not necessarily around dental care, but we said, if you could work with people around dental care to do a process of behavior support and desensitization and help them sort of gradually approach the idea of getting dental care, what percent do you think who are currently having care under anesthesia could get care in a more normal manner either in the community, like I said, or in a dental office, or the combination? And their answer was 80%. I was sort of blown away by that. I actually think that's too high. I don't really believe 80%, but my guess is 50%. My guess is we could shorten that line by 50%. And certainly the behavior support therapist saying 80% made me feel a lot better about my prediction of 80%. We then met with a group of dentists. We asked them about what are the barriers you see to being able to accept more people in your office. And these were not new to me, but it was good to have them repeated by the dentists in the focus group. So they talked about fees, paperwork, training, extra time. It throws off their schedule, non-compensated time. People need extensive care. People don't keep appointments. And then they have this whole hassle getting information. They're not sure about getting a complete health history and who's in charge of consent and all that sort of stuff. So we posed a couple of questions, a series of questions to the dentists in this focus groups. And the series of questions were about, okay, what would make a difference? What would help you being able to say yes to more people to take them into your practice? We asked them about training. If we give you additional training about people with disabilities, would that help? And the answer was, well, yeah, it would be somewhat helpful, but it doesn't address all the problems with fees and time and behavior information and scheduling and appointments. So yeah, somewhat helpful, but not enough to push us over to really want to do it. We asked them about what if you had additional training about behavior support strategies? Would that make a difference? Same thing. Yeah, it would help, but doesn't address fees and time and information and scheduling and appointments. What if we helped you get all the information you need so you wouldn't have to worry about problems understanding who's able to give consent and what the health history is? And yeah, that would help somewhat, but doesn't really address fees and behaviors and scheduling. We asked them, what if we were able to give you targeted referrals, meaning before you saw someone in your office, they were pre-screened and they'd had some preventive procedures that were done prior to getting to your office. And we could even give you a warm handoff about the behavior support plan, so you'd know what kind of things have helped this individual get through other kinds of procedures. There was a little bit more enthusiasm about that, but still didn't address fees, time, information, scheduling. And then finally, the question was, and I think this is the important thing to pay attention to, what if we did all of this stuff? What if we provided you with additional training about both considerations for oral health care for people with disabilities, about behavior support strategies? We gave you all the information you needed about health history and consent, and we made sure that you had a teledentistry linkage to the people who were working in the community, so that the individual might get first seen in a day program or in a residential facility or some kind of other community setting, that there would be a hygienist working with them, doing desensitization in connection with a behavior support specialist, that they would get to the person to the point where they're already used to having things, lights in their, things in their mouth, and gloves, and people dressed up all weirdly with masks and all that kind of stuff. And they were already doing pretty well in the community. And then we actually gave you training about these minimally invasive dentistry techniques. And then when you got a targeted referral, it was someone who had already been through that, and we could tell you exactly what's going on with that person. And someone's already decided this person's ready to now sit in your dental chair. And we could also pay you for extra time. So if you had to do 1 or 2 get to know you visits, and that's when the dentist said, okay, I get it, sign me up. I'll be willing to do that. So this gives me a lot of hope that the system we're building and hope to test in the next couple of years would be exactly this. So it's to be all these things that we're putting together in a package. We're already beginning the process. We're talking to several funders who we hope are going to be interested in helping us support this project. And we hope that we can actually be able to put this in place, really demonstrate that we can shorten that line, building awareness, addressing and use the information from this demonstration to address the policy barriers, increasing incentives and rewards, and focusing on outcomes and health costs, and that this is actually going to be something that can be a major difference in the way we think about supporting dentists and producing a viable system. I've been involved, as I said, for a long, long time, and I've seen lots of examples of people doing little bits of this. I've given many courses myself. It makes a little difference, but mostly not a lot. And we think really this is the answer. We've got to put all these things together in a package, and we're very excited and hopeful that we can make a difference. So that's the shortening the line part. I just want to add a couple little things very quickly at the end here. In the meantime, if you're a parent or a caregiver, are there some things that you might be able to do that can start to make a difference or help to prepare the person you're caring for to be a little bit better able to receive care in a dental office? I want to, again, start with the disclaimer that this isn't going to be useful for everybody. There are some people I think these things I'm about to say can make a difference. Other people probably won't. But for what it's worth, I want to just throw out some ideas. These are all things that I talk to dentists about when I give courses, but I want to take the opportunity to put out a few ideas here for the caregivers and parents who are in the group. So first of all, I think, Annie, you already pointed out the challenge in the first one, which is there a dentist who's willing to work with you at all, period? Now, if you can't find a dentist who's even willing to get engaged, then there's no point in going through the rest of this, because it's not even a starter. But if you can find a dentist who says, okay, well, yeah, I'd like to do something, but it's really been a challenge for me. It hasn't worked out very well in the past. Can we do something different this time? How can we make this so it's more workable? I have some tips about how to work with that dentist. So first of all, it'd be finding a dentist who's willing to talk to you kind of offline, not in the middle of a dental appointment, is willing to talk to you and develop some kind of a plan. Maybe try to figure out what will help. This slide is a slide of a survey that was done with a group of parents, actually from in New York. This was a number of years ago, but they compiled some things that parents typically feel would make a difference. And these are things that they try to tell dentists that if you're going to see people with disabilities, try to pay attention to this stuff. So first of all, make sure dentists have the background of the person's condition. Make sure you're treating the caregiver and the individual with respect and dignity. Recognize family strengths. Many dentists or many families have things that they've worked out. They know some strategies that can make a difference, and the dentists don't take the time to ask or learn what those are. So figure out what are the strengths that you already have. Make sure you have short wait times, acquired appointment. Maybe that's the first appointment in the morning, or don't do this when you're at a time in your office when the waiting room is going to be crowded and you're already going to be running behind schedule. Allow extra time for the appointment, and listen to the individuals and caregivers express needs and suggestions, both verbal and nonverbal. So the dentist may need some training on what nonverbal cues are to pay attention to, and then emphasize the individual's abilities, not the disabilities. And one of the things it doesn't say on this slide, but I think it's part of the second bullet, is when you're talk to the individual, don't talk to the caregiver. A lot of people, when there's someone who's not very verbal, they tend to turn and talk to the caregiver instead of talking to the individual. So respect the individual's dignity by talking to the individual. All right, so if you have a dentist and you can have who's willing to plan with you, can think about some of these things. Maybe you can actually provide the dentist with some history that can help the two of you plan together about what might make a difference. And when I think of history, again, when I'm talking to dentists, I tell them, these are the things you should think about in history. Understand for that individual, what's a typical day? What make experiences, non-dental experiences, what make things go well? What kind of people, objects, approaches can make a difference? What leads to difficulty? So you can try to translate that into the dental environment. What are previous experiences that can make a difference? Suggestions or desires for the dental visit. Think about the person's communication ability. Maybe someone is has verbal skills or maybe not. Well, how do they express themselves? What kind of cues can you look for? When someone's getting frustrated in the middle of a visit, how do you know that? What kind of signs might there be that something's about not going so well? Find out what coping methods and skills are. So these are all history things that if the dentist really fully understands that, can make the approach go better. And then finally, the possibility of practicing at home. And Annie, again, want to note that you noted that this is not always so easy to do. So again, I don't say this with any think that it's going to work for everyone, but maybe for some people, practicing at home, and that could be practicing at home, could be in some ways recreating the office environment. Just playing dental care if that's appropriate. So putting on a mask, getting the plastic mirrors you can buy at the drugstore, putting on gloves, just taking a look at the teeth with a flashlight, maybe just to simulate the light in the office. And if you can get someone just used to that kind of game environment, playing, just getting used to sitting back in a chair, lying on a couch, having someone shine a light in their mouth, holding their mouth open. And then if that can gradually increase to a little bit of brushing and then maybe more brushing later on, it sort of simulates a dental environment. And if you can introduce an electric brush, which kind of has that vibration, which might sort of simulate a little bit the dental drill, I say the more someone's used to as many elements of a dental visit as possible before coming into the dental office, the less new stuff in the dental visit, the better it's going to go. And then finally, the whole thing which you mentioned also, Annie, about social stories. I won't have time to read this one now, but this is just an example of a social story that, particularly younger kids love to have stories read to them, sometimes over and over and over again. I know my grandkids and my kids, when I was reading them stories, I would think, I read the story 50 times. I don't know why you want to hear it again, but they did. So I kept, so sometimes these stories, this one's about going to the dentist. And finally, if you can advance, they have books on social stories about going to the dentist. But if you even get the dentist who's willing to work with you to give you some pictures of their own office, or you go to their office and you take some pictures of the parking lot and the front door and the receptionist and the dental chair, so that the person you're caring for can read the book and look at these pictures. And when they actually come to the physical office, it's not new. They've seen the picture. They've seen what the dental chair looks like. They've seen the receptionist before. So it all seems much more familiar. And then finally, figuring out, as I said, is going to be part of this project we're working on, if the dentist is willing to have some kind of get to know you visits, where the first couple of visits don't have to be for actual treatment, but just to get introduced to the office. So there's a lot of stuff that I mentioned that I could talk for a lot more time about, but I don't have time to do it. But I'm just very, very excited now that we've reached a stage where I think we're about to start this demonstration. My hope is going to really be able to show that we can shorten these horrible lines for anesthesia, build awareness, use the results to address the policy barriers, and then provide implementation support and dollars for training and technical assistance, and help to spread this whole idea so that it becomes much more, not just a little demonstration project off in a corner, but actually a very mainstream part of dental care for people with disabilities. So that's my email address on the slide. And if you want to contact me, I'd be happy to talk to anyone about any of this stuff further. So Ben, I will stop sharing here and turn it back over to you.
Thank you so much, Dr. Glassman. Thank you, Ann Hall. Thank you, Mary McCune. There is one question in the Q&A, and before we go into that, Dr. Glassman, I just want to tell everybody that at 1 o'clock is the last keynote address that we're hoping you will join us at. When the window closes, look for the event website on your internet browser to click join for that next session, okay? The question that is in the Q&A comes from Hannah Au, and the Commission of Dental Accreditation. This is about the CODA accreditations that changed in 2019 to require dental schools to train students in treating patients with intellectual disability and developmental disability. Do you see this positively shifting the workforce shortage? And do you currently see it being implemented in schools, Dr. Glassman?
Well, it clearly is implemented in schools, because a school to be accredited has to do what the Accreditation Commission says. So there's no question that every school is going to try to meet that requirement. And I was involved in that requirement. I think it was a fabulous step forward in getting that into the accreditation requirements, but it is very general. It says that every student has to have some experience treating people with special needs. Special needs is defined very broadly, and I think it would be unfortunate to think that this is going to solve the problems that we've been talking about for this panel. It's going to make a little bit of a difference. People will have some more experiences, but I think without all the other components that I just talked about, additional training is not going to make that much difference. I've been involved in dental residency training for 20 years in my career, where we were training students who graduated from dental school to have extra special training. And in those, they got a lot of training on working with people with special needs, and yet most of them didn't do it when they got into practice. And so clearly training all by itself, training is absolutely necessary, but all by itself, it doesn't address all the other barriers that I just listed on those slides you just saw. And that's why I'm very convinced now that we have to do packages now, put things together where we address all of those barriers for dentists. Simply training all by itself, I don't believe is going to make all that much difference. And I hate to be pessimistic about that, but I'm optimistic about the alternative, which let's put together all these other pieces that need to be part of a solution.
Dr. Glassman, what is your email again? A lot of people were unable to get it down fast enough.
Oh, I'll put it in the chat here.
Great. And with that, Ann Hall, Mary McCune, any last words before we close up and send everybody to the keynote?
Sure, I'm happy to jump in and just say thank you, Dr. Glassman, for those ideas. Just because I've had struggles in my own home doesn't mean that we don't need to try new ideas. And it's good to not feel alone, to have supports, and to have some of these ideas. And Mary, thank you for all the work that your organization, all the professionals you're working with are doing. I mean, it's a huge step. Just because I had this one individual encounter with my dentist that was like, gosh, now what do I do? That doesn't in any way take away from all the work. And I'm hungry to hear what can I do? How can I try to say, yeah, this is a great idea. How else can I try to advocate to get these things going in my area? So thank you all for the work that you're doing on behalf of our kids and caregivers.
And with that, go ahead, Mary.
Oh, yeah, and I just wanted to reiterate what Anna said and what I've said earlier of, our advocacy is really integral on the experiences that parent advocates like yourselves have, and it really helps inform to make sure that what we're trying to advocate for gets implemented appropriately and actually has the biggest impact as possible. So we're really excited to partner with Family Voices. We're excited to continue the conversation with groups like yourself to make the most meaningful impact as possible.
And I want to end with one of the chat items from Danelle Kenworthy, who says, good to see movement, but more work to be done. Absolutely true, Danelle. And please, thank you for being part of this, everyone who attended, and enjoy the keynote session. It's been a great summit.